Welcome to this recorded session from the FMEC Young Breast Cancer Survivorship Series, a 5-part webinar series focused on the unique needs of young breast cancer survivors. This series is part of a multi-year initiative to enhance breast cancer prevention, early detection, and survivorship support in family medicine. We thank you for joining us today and encourage you to explore the resources developed in the earlier phases of this project, and also to keep an eye out for future activities with FMEC. To learn more, visit the FMEC website or use the links provided in the description below. The American Academy of Family Physicians has reviewed this series and deemed it acceptable for AAFP prescribed credit. Please see the description below for more information. We would also like to acknowledge the support that makes this work possible. The FMEC Young Breast Cancer Survivorship Project is supported by the National Association of Chronic Disease Directors through funding from the CDC's Young Breast Cancer Survivors Program. We pick up this recording at the start of the session with our presenters for Module 2, Dr. Barbieri and Dr. Sivendran.
My name is Jennie Barbieri. I am an internist, and I'm also the founder and director of Bridging Oncology Care and Wellness Recovery at AMB Barsinger Cancer Institute at Penn LGH. I'm also the mother of a childhood cancer survivor. I'm now going to send it over to my co-presenter, Dr. Shanthi Sivendran.
Hi, everyone. Glad to be back. Shanthi Sivendran. I am a medical oncologist practicing Penn Medicine Lex General Health. I'm also Senior Vice President of Cancer Treatment Support at the American Cancer Society.
Disclosures: we have no relevant financial relationships to disclose, and we will not discuss off-label uses or investigational uses of any products in this presentation. So, learning objectives. We want to recognize the growing need of young female breast cancer patients. We want to make sure there's equal access to healthcare. We want to empower and listen to our patients. I also want to empower our primary care doctors that they are very well suited for managing the long-term and short-term side effects of treatment. What is the plan to optimize care of young female breast cancer patients? And I want to give some examples of how we can use electronic medical record. In particular, we use Epic, where we are, to achieve goals, and the role of the comprehensive care team and their goals. And I really want you to think about how you can apply some of the things you learn here to your practice. My personal goal today is to use evidence-based medicine to help you better care for the needs of your patients. This is a really highly motivated population of patients, and we have tremendous ability to affect their health at a young age by applying wellness. Okay, so survival is on the rise. So why is this relevant to your practice? Why are there grants given to educate family practice on this topic? Well, survival's on the rise, treatments are getting better, detection's getting better, and so now we have this opportunity and need to care for this growing population of patients, in particular, young female breast cancer patients. So I'd like to draw your attention to the difference on the left side, where I have circled the difference in incidence of cancer showed on the left, compared to, on the right, the mortality. So we see that there is a higher incidence in the white population for the incidence of breast cancer, but there is a higher mortality in American Indian and Alaskan Native. So we have an opportunity here to recognize the difference and meet the screening needs of all our patients. We need to be on alert. We need to make sure that our patients are being listened to and listened to in a way that is appropriate for them, and make sure they're getting access to screenings and treatment. So how do we close this gap in healthcare? We need to hear their voices. So the American Cancer Society has launched this study it's a cohort study to address the important gaps in understanding cancer health outcomes in African American women. It's Black women aged 25 to 55 years, and here is the information on how to refer patients and consider if you have patients who could participate, because this is how we will gather the data necessary to close the gap in healthcare. So state of survivorship in younger patients. What are patients not telling us? This study is for age 18 to 39. So it captures this younger patient group of patients who have cancer. So side effects experience. So I want to call your attention to the left side, the little banner on the left. So it says 99% of younger patients experience at least one symptom during or after treatment, compared to patients 40 plus who still have a high percentage of having one or more symptoms, but it's lower, it's 92%. So majority of younger patients experience pain, fatigue, and depression or anxiety during treatment, all significantly higher than those age 40 plus. Interestingly, younger women also have a higher incidence of any side effects compared to men. Pain can be from prior surgery, from their breast cancer surgery, or their staged breast cancer reconstruction, or neuropathy, secondary to chemotherapy or radiation skin irritation. Fatigue is common. Radiation causes a profound fatigue, secondary to the rigorous daily schedule of radiation, but also because your body is healing from the damage being done to their cells. Depression and anxiety we will discuss later on in this talk. So goals for caring for young female breast cancer survivors. I want you to identify one step that you can take to optimize your care of young female breast cancer survivors. Patients don't, I want you to be aware of the invisible needs. Patients don't always walk in readily sharing. Not everyone identifies with the term survivor. So it's important to look at their electronic medical records, see in their history if they have it, and ask them where they are in their cancer journey and how they're feeling. This is where the strength of the primary care physician relationship can really shine. If they trust you, they're more likely to share with you. Automate EMR to support your care. So at our Cancer Institute, we have a lot of screens for mobility, for depression, anxiety, for lack of access to financial access to buying healthy food or transportation. So we have ways to identify who has needs and who we can support. So it helps me that before I even walk into the room, I know areas I need to make sure we discuss. Use patient-friendly handouts. I think this is really important. I have patient-friendly handouts that are already preloaded into Epic. Epic often already has them in the system. So I had my tech person help me preload them. So when I do the wrap-up at the end of the visit, I can click on sleep hygiene information and different handouts that are pertinent to what we talked about. So what is your plan to optimize your care for young female breast cancer survivors? I want you to think about that. So comprehensive care team goals. So in the center, you'll see we have the oncologists and the patients curing the cancer. Then we need to support the family needs, meet the patient's needs, and obviously trying to make this very complex journey a little simpler so they can better work through the different phases from diagnosis to treatment to recovery. So we need to work together to communicate and coordinate to meet the family and patient needs. And really we need to listen in order to do this. So those of you who attended Module 1 may remember this wonderful wheel that Dr. Lucking created. So it's the pivotal role of the family physician. And at the center, you'll see family physician continuity across the cancer journey. And it talks about the role of prevention and risks, which we primary care doctors are involved in with all our screenings that we order and wellness and physicals. 2 is early recognition. 3 is lifestyle changes to help manage their chronic diseases and prevent developing diseases. Making the complex care co-managed with our oncologists and other specialists, the breast surgeon, the radiation oncologist, physical therapists, and then whole family care. And now I'm going to turn it over to Dr. Sivendran to talk about survivorship and surveillance.
Perfect. Thank you. As I think about this, and I'm thinking about it from the medical oncology lens, we talk about, Dr. Barbieri really set up that when we think about survivorship, there's different components of this. And the surveillance component of this is something that is sort of deeply rooted in medical oncology, but is very influenced by what you're seeing in primary care, right? So, most patients are seeing both of us at some point, and our young breast cancer survivors may come to you and bring up, a symptom that, may prompt a discussion between you and me, or a symptom that might prompt you investigating whether you're worried that this is something like breast cancer recurrence. So when I think about breast cancer surveillance, I wanted to give you an idea of how all the different components of that surveillance. So the first is that young breast cancer patients in survivorship, and so this is like they've finished sort of their active treatment, something like their chemotherapy, or sometimes people get immunotherapy, but they may still be on something like endocrine therapy, right? Like anti-hormone therapy. So kind of that sweet spot in there. And the assessment of a patient should be at least annually with a standardized tool. And we'll kind of harp on that. So, it's not sort of a don't ask, don't tell kind of situation with taking care of young breast cancer patients. Young patients actually any patients, right? We know may not know what to bring up. They may be attributing their symptom to something else. And so having a standardized tool to go through and prompt a patient to think about what are the different things that may be going on that are just like not landing right in their life is really important. And I'll show you one in a little bit. So when I think about breast cancer surveillance, history and physical exam, these come from the National Comprehensive Cancer Network guidelines, or NCCN guidelines. So we do that 1 to 4 times a year for 5 years, and then annually. And here we're screening for we're looking for anything that might prompt us to look for metastases, right? We don't actually always do imaging in labs routinely. There are exceptions to that, but we're doing them based on suspicion of symptoms. 1 to 4 times a year is a really broad way to say that. I, as an oncologist, make a decision based on how high risk I think a patient might be. But generally, we're seeing patients at least twice a year in survivorship. And then periodic genetic screening for changes in family history and genetics referral if needed. So I have this really interesting, I was in clinic this week and somebody said to me, actually it was a patient of mine with melanoma, and he said, hey, we had a relative who had the BRCA, my father had the BRCA mutation, my sister died of breast cancer, but my doctor said I didn't need to get tested. And, what we know, and the reason was they said, well, you don't need to get tested because you're not going to get breast cancer. And what we know is that, first of all, men can get breast cancer, 1. And 2, that genetic mutations put patients at risk, oftentimes for multiple different types of cancer, right? So I would always err on the side of periodically updating sort of family history and understanding, hey, there seems to be a lot going on here, a lot of different cancers, and then understanding in where you practice, what are the referral patterns? How do you get somebody to a genetics program to be evaluated? Mammogram every 12 months or more often if high risk, and so there are protocols for that. That's something that you can coordinate with the oncologist depending on the type of breast cancer that somebody had. And what I love about my primary care colleagues is, you may see the patient before I do, notice that the mammogram isn't ordered, and you order it. Or I may see them before you do, and I order it. And it's not a turf war. It's like we're all together in the help of the patient. Cardiotoxicity monitoring for patients who received anthracyclines, HER2-targeted therapy, left-sided radiation. Like we can survive cancer, but we can't live without our heart. And so, we're hoping that these young patients have lots of years in front of them. So really making sure that we're monitoring for that, and that there'll be more on that as we go. Encourage adherence to endocrine therapy. So a lot of these young women are on tamoxifen, right? So tamoxifen is what we use for women who are still menstruating, and age-appropriate gynecologic screening. Like, it is tough. So if you have patients who have been on endocrine therapy. I often say like menopause, perimenopause, and menopause. Like I'm getting in that perimenopause phase, and none of those things are fun or exciting for anybody. And these young women, they're instead of like gradually going through it, I often describe it as like they're hitting it like a brick wall, right? Because they're starting the medicine and then it's like full-blown menopausal symptoms. And that's really hard when you're young and you have multiple responsibilities. So understanding what those symptoms are, thinking about, and we'll talk about this, thinking about how we can manage the symptoms and coordinating with the oncologist is important because adherence to those medicines is what improves survival. And then, hey, we need our bones, right? Like, and like we can also have our heart, but we need like the skeleton to keep us up, right? So baseline and periodic monitoring of our bone mineral density, because we know that some of these women might be on an aromatase inhibitor, right? If they say had their ovaries removed. And so, or who have secondary, or who have ovarian failure secondary to treatment. And those women are actually at risk of osteoporosis. Next slide, please. And then as we think about, so that's surveillance sort of in a nutshell. And I think my takeaway for that is like, we're both involved, right? And that there may be in the beginning, like years of survivorship, there may be a heavier hand by the oncologist, and maybe in later years of survivorship, a heavier hand with the primary care physician, but we're working together, right? Like the more communication, the better to make sure that we're actually meeting the needs of our patients. And then there's the whole, like, so if we think about that bucket of like, what is survivorship? We talk about surveillance, but then there's all these other elements of survivorship. And the NCCN, or National Comprehensive Cancer Network, has nicely outlined, like, what are some of those big buckets that we need to think about? So I've put these here, and Dr. Barbieri mentions a lot of these as we went through. You'll see that some of them we're going to talk about today, and some of them we're going to talk about in further sessions because they deserve more attention, like, you know, for a full lecture. But you can see, like, there's a lot to think about. And when there's a lot to think about, Dr. Barbieri, if you can give me the next slide there. And when there's a lot to think about, I lean on assessments, right? Because when that patient is sitting there in front of you, like trying to like tick off all those boxes in your head of like, did I ask about that, can be really hard, right? And so we, in the clinic that I'm in, all of our patients go, you know, do some form of survivorship assessment through medical oncology. And then as we collaborate with our other partners, we do, you know, various assessments. But this is one example, right? It's not the only survivorship assessment out there, but I put this in here with credit to NCCN because I think this is a nice one that lays out, so this is when you give to the patient and you lay out, hey, look at these, and does this resonate with you, right? Are you having any of these issues? And so what I would suggest is take a look at something like this, and then we will, you know, go through it and say, and remember that like a young patient, especially a young woman, might tell you that their pain level is a 5, but like the scale of that for them may be actually like a 10, right? So like they may be underplaying some of these symptoms. And so using the assessment as a guide, but then when somebody attests to something that's difficult, then jump in and, you know, really dig deep into that specific symptom. Next slide, please. I'm going to touch briefly on a couple topics. So for young women, we're thinking about fertility, birth control, and menopause. So when we are thinking about like before starting treatment, things that I do for my young breast cancer patients, premenopausal patients should be counseled on treatment impact, on fertility, future desire for pregnancy, offered fertility preservation, non-hormonal methods of birth control should be encouraged. And then I have patients who, you know, they're young and they haven't had a child and they'd like to try. And so patients wishing to get pregnant during adjuvant endocrine therapy, there's data that shows that they should complete about 18 to 30 months of treatment first, and then you can temporarily interrupt endocrine therapy for up to 2 years with similar outcomes. So that's important, right, to know as a primary care physician so that it's not like a closed door necessarily for these women in their ability to have a child if they so desire. And then menopause, like I say that knowing if you're have gone through menopause is like knowing if you're in labor, like both are very difficult to know. And so the definition for menopause is amenorrhea frequently occurring during or after chemotherapy for the majority of patients under 35. Most of those will have their menses return within 2 years. So for a woman to be considered postmenopausal, even on endocrine therapy, she must have no menses for 1 year and must have biological markers in postmenopausal ranges. And that's important, especially as we think about endocrine therapy decisions, that we can't switch from like a tamoxifen to an aromatase inhibitor too soon, right? Because if you're still actually not menopausal, then you're not getting all the protection you need from that anti-estrogen. Next slide, please. Hormone-related symptoms, so tough, so tough. So because you're on these anti-estrogens, you're like hitting it like a brick wall, menopause like a brick wall. So vasomotor symptoms, vaginal dryness, urinary symptoms, your genital symptoms, where they feel like they're like always feeling like they have a urinary tract infection, but it's not actually a urinary tract infection. I've seen patients go on multiple rounds of antibiotics for something that is not a urinary tract infection. Sexual dysfunction, sleep disturbance, mood, cognitive dysfunction, like feeling so achy, feeling like you're 90 years old, right? And then the fatigue. Next slide, please. So for vasomotor symptoms, there's some options you can think about. There's some things to remember. So menopausal oral hormone therapy is contraindicated in breast cancer survivors. So you first consider non-hormonal pharmacologic treatments. So things like weight loss, right? If obese or overweight, like estrogen is made in that fat tissue, acupuncture, exercise, lifestyle modifications, integrative therapies. These are really important, like all things that before we jump to a medicine, although a medicine can be really life-changing here, but things to like incorporate in addition to potentially medicines, right? And then non-hormonal pharmacological treatments, we very historically used venlafaxine. So in the same way, like, I always thought this was really interesting, right? Like using an antidepressant for vasomotor symptoms. We do that for smoking cessation, right? And other things. So here you can use venlafaxine, sometimes gabapentin. I will say I haven't had great results with that. I've had better with venlafaxine. But now we have these new selective neurokinin NK1 and NK3 receptor antagonists that are like late breaking, I guess, like in the past couple of years, and patients have had really a lot of improvement in their symptoms. So these are all, like, as you're going through your algorithm, things to think about. Next slide, please. And then I think I end here just thinking about, like I said, like, you can't forget about your heart because you can't live without your heart, right? So when I think about the heart, I'm thinking about the heart right at the beginning. So before I even start treatment, I'm thinking about assessment of cardiovascular disease risk and then referral to cardio-oncology. That's a whole subspecialty in itself, and using tools to quantify that risk. And I'm often doing that in conjunction either with my primary care colleagues or my cardio-oncology colleagues. And then during treatment, assessing for heart failure signs, because some of those cardiotoxic medicines, and we're doing baseline, maybe say echoes or cardiac functioning, and then periodically based on symptoms and risk. And then survivorship, we're thinking about all the things that all of us should be thinking about, but like are even more important for our young breast cancer patients: tobacco cessation, diet, weight management, diabetes prevention, exercise, blood pressure monitoring, cholesterol, all super important things. So I think I'm turning it back, maybe next slide in case I'm lying about that. Turning it back to Dr. Barbieri. Thanks for including me.
Of course. Thank you so much, Dr. Sivendran. That was excellent and so helpful to hear the oncology perspective. So in this slide, I have risk reduction. So therapeutic options, which Dr. Sivendran just talked about, which are the anti-estrogen treatments to help reduce cancer recurrence risk. She talked about the tamoxifen, and for some people, aromatase inhibitors like anastrozole. And then I'm going to delve into more lifestyle and cardiovascular. So Cardiovascular, we are in a good time right now where we have this our cardio-oncology field, and we have new risk stratifying tools for atherosclerotic cardiovascular disease. We used to only have a risk calculator that didn't include the 30 to 40-year-old population. It started at 40, and now we have a tool that we'll talk about, and Dr. Sivendran mentioned, called Prevent. And there's also a new one on the horizon that includes other oncologic treatments that increase cardiovascular risk. So we'll get to that in later slides. And lifestyle. So young female breast cancer patients are at risk for weight gain. A lot of times, the anti-estrogen meds definitely make losing weight very challenging, and it can be very frustrating. You've already had all these body image changes from surgery, and then on top of that, you're now put on anti-estrogen medicines that throw you into menopause, and you are gaining weight. And so using lifestyle changes to help patients work on the pillars of wellness, which we're going to discuss later in the slides, can really be a way to put control back in patients' hands to work on the weight gain that often comes with the breast cancer journey. So I want you to know about these NCCN, the National Comprehensive Cancer Network guidelines for patients. This is what I use in my oncology wellness program. It's called Survivorship Care for Healthy Living. My program is now celebrated 3 years. And when I started the program, we only had the 2020 guidelines, and we'll talk about some of the updates of the guidelines to these 2024 ones. But the guidelines are great to have, but you also need to have an empowering approach to care for young breast cancer patients. So I have found that the lifestyle medicine approach really encourages patients to reassess what is a healthy habit they want to keep and what is an unhealthy habit they want to change. So if you've ever been around or lived with, as I did, a cancer patient, the treatment hurdles are not small, and they have to do what they can to survive treatment. So patients often have to modify their activity level, their eating habits. And so when you get to the end of treatment, or if you're on chronic treatment, you want to really assess what are healthy habits you want to keep, and what do you want to change. And you really want to empower your patients to lead you in that journey, because we don't live with them. Only they know that. And you want to encourage them to pick what they feel ready to work on. So first of all, what are the pillars of wellness? So I sat down with one of my oncology colleagues, or at the time she was just a friend, and we discussed what are the NCCN guidelines for wellness for patients and what are the wellness guidelines for lifestyle. We saw that there was a pretty clear overlap. So the pillars of wellness are nutrition, exercise, restorative sleep, stress management, and avoiding risky habits. I would also include in stress management having a social network, because we definitely have seen that having support in a social network definitely reduces stress. So beyond survival, how lifestyle medicine elevates cancer survivorship. So life after cancer often comes with a unique set of challenges, but lifestyle medicine provides a core strategy for improving survivors' quality of life, function, and long-term health. So as Dr. Sivendran said, there are a lot of components, and in helping patients break it down and pick having the power to let them choose what they feel could be improved and what they want to start with is really a great approach. It helps give them a path back to feeling better and feeling more like themselves. We do often talk about how there is no going back to before cancer, but it's about forging a new path forward and about creating the next curated portion of their life that hopefully, that includes improving their wellness. Okay. So this slide I really, really love, because I know that my audience here are family medicine doctors from across the country. So you may be in an urban environment or a rural environment. You may have a population that has limited resources socioeconomically, and you may have people with very busy lifestyles. A lot of time, young female breast cancer patients are at one of the busiest times of their life. They might be caretaker to young children. They might even be starting to have aging parents. And so, what I have found is you really have to get to know the patient and know their current lifestyle and know them as a whole person. And again, this is where I think primary care shines because we often have that relationship with patients and their families. So, in the urban core environment, you may have people who have less access to fresh food or markets. So, they might be easier for them to buy frozen food or shelf stable food. Um, in a rural environment where I live, in more of a rural suburban environment in Lancaster, Pennsylvania, um, you can find frozen, canned, very seasonal food, and you can freeze it, or people here can for winter. There's a really like a farm history here, and people often do know, some patients know how to do that and store their garden vegetables to make it last through the winter. Um, Limited resources like income. So beans, oats, lentils, frozen vegetables can often be more affordable than other foods. And people with busy lifestyles, I really encourage them to meal plan and keep things simple. I have patients who order all their meals right now off fast food apps and don't know how to cook. I have one lady who grew up in foster care and only had limited access to a kitchen because she had an apartment and she didn't live on the floor with the kitchen. And then I have patients, who are somewhere in between, but are so busy with work and young children. And then I have people who are really into cooking, or they have a spouse or someone else in the household who's really into cooking. So I encourage them to involve the family in the meal planning for at least the weekdays, and they can have a template. Like in my household, we have Taco Tuesdays. Sometimes it's um, a non-animal fat, and sometimes it is with ground chicken or turkey, so a lean meat. And sometimes, and when we have Pizza Friday, so people can pick. They don't have to reinvent the wheel every day, but they can have a template and then um, figure out their other dinners and write it on a piece of paper and put it on the refrigerator. So, and then make a grocery list at the start of the week so that you have the components, the ingredients to make your meals. That can really, people really do find that can be very helpful, and it reduces their ordering out or eating out as much because they have a plan and they don't want their food to go bad. Um, we definitely encourage eating more of a whole food plant-based diet. So we'll get into that now with nutrition takeaways. So nutrition takeaways. The relationship between diet and breast cancer is complex, and there's no single breast cancer diet to cure or prevent breast cancer. So we need to look for foods that support overall systemic health. So fiber-rich diet. So we want an anti-inflammatory diet, and one type of anti-inflammatory diet is a Mediterranean style diet, which is rich in fiber and healthy fats, which lower inflammation, thereby lowering breast cancer risk. We want to encourage reducing processed foods. Consider cutting down on highly processed foods, trans fats, and added sugars to protect metabolic health. A big thing, whole soy foods are safe and potentially protective. You'll get asked this a lot from your breast cancer patients. And I've talked to my nutritionist, and she has said it's okay to have some soy foods like edamame. That is okay. Another big thing is alcohol increases breast cancer risk and many cancer risks. So it's important to limit it. So the NCCN wellness guidelines for survivorship, when I started my program, we had the 2020 ones, and it said that women can have 1 glass of alcohol a day and men can have 2 a day. And the 2024 guidelines have reduced that. They now say no more than 3 to 4 glasses of alcohol a week, but really any alcohol increases cancer risk. So I tell my patients, when my husband offers me a glass of wine at dinner, I always think, do I really want that? Because it's not without risk. And I encourage you to continue to delve into the alcohol. I have also seen that some of my cancer survivors have spouses with alcohol problems, and that's causing a lot of increased stress too. So again, utilize your relationship with your patients and their family to help uncover the alcohol use, whether with the patient or their family member. It's also important to decrease portion size and we talked about meal planning. So benefits of physical activity in cancer survivors. So I really like this NCCN chart here. So the benefits of physical activity are really quite broad. They improve your cardiovascular fitness because it allows your body, it affects how your body takes in and transports oxygen to all the tissue in your body. It improves muscle strength. It improves muscle, bone, and joint health. Better balance, which becomes even more important as you get older. But certainly when you're pregnant, that's important too, as your center of gravity changes. It reduces fatigue. This is a big thing that we'll talk about later about cancer-related fatigue. Exercise is the best thing you can do for cancer-related fatigue. It also improves your emotional well-being. It improves your quality of life, and it helps lower your risk of cardiovascular events. So, exercise. What do you recommend to your patients? You want to encourage cancer survivors to move both pre-treatment, during treatment, through treatment to do what they can, and after treatment. You want to encourage them to start slow and gradually increase their exercise. You want them to have a warm up and a stretch to help prevent injury. And you want to encourage them to do at least 150 to 300 minutes of moderate intensity activity. I really encourage patients to look for resources. The American Heart Association has 7-minute workouts. There's chair yoga that can be for free. A lot of health systems have online access, but there's a lot of excellent, trustworthy sites that I'll make sure in subsequent modules that we put up some more of these resources. But the American Heart Association 7-minute workout is a great one. All right. So implementing exercise. This book is really wonderful, I think, for all physicians. It's written by a Stanford psychologist on behavioral changes. So it's called Tiny Habits, the Small Changes That Change Everything. So a friend recommended this book to me, and I read it before I started my program, like a couple weeks before I started my Bridging Oncology Care and Wellness Recovery program. And it talks about how important it is to schedule your exercise. So I encourage my patients to look at their schedule for the week and figure out and write down on a calendar when they're going to get their exercise in. This book encourages you to attach a new healthy habit to an already existing anchoring habit. You want to choose cardiovascular exercise and strength training. So back to the anchoring habit. An example of a healthy anchoring habit is brushing your teeth. So one thing that you can do is after you brush your teeth, the author talks about how he wanted to start doing pull-ups. So he installed a bar in his closet, and after he brushed his teeth, he went and did pull-ups. He started with 2 and he built his way up. You want to include cardiovascular exercise, which could be walking, running, um, aerobics classes. You want to encourage patients to pick what they enjoy doing. And you want to encourage them to pick the time of day they enjoy doing it. They're most likely to do it. You want to encourage them to pick if they do group exercises, individual exercise, or a combination. You want to encourage them to also include strength training 3 times a week, which could be yoga, chair yoga, bands, resistance bands, or gentle weights. You want to be reinforcing the activity, reinforcing what you're doing as you're doing. You don't want to wait 2 months. Oh, I'm going to wait and celebrate when I lose 20 pounds. No, that will take months. You want to be celebrating you're doing it while you're exercising. And I encourage patients afterwards to check it off on their calendar, star it, to really celebrate their effort. So sleep. This is from the Mayo Clinic. It talks about healthy habits for a better night's sleep. So you want to take a good sleep history, especially in your young female breast cancer patients. They may have young children who are either co-sleeping or waking them up. You want to encourage them to take back control of their sleep and ask for help in their household with bedtime. The goal is 78 hours of sleep, and often the estrogen inhibitors really affect sleep. and it can be very frustrating for patients. So we will talk about sleep hygiene techniques, which are right here. So it's important to have a routine of when you go to bed and when you wake up. It's important to eat light at night. So your bigger meal should be earlier in the day so that you're less likely to get acid reflux when you go to bed. You want to minimize blue light. I say to patients, it's okay to have a phone in your room if you need to be reached for emergencies, but it shouldn't be reachable from your bed. So in my house, we keep it on a windowsill charging in case our older grandparents or parents need to reach us. You want your bed to be only for rest. You want to limit caffeine, nicotine, and alcohol, and you want to make sure you're doing exercise during the day and getting sun exposure. So stress. Stress is a big player in the cancer journey for young female breast cancer patients. So I say the 3 M's are how we help reduce stress. So mindfulness, meditation, and mindset. So mindfulness is when your patients start to feel their mind going down the rabbit hole of worry. What if the cancer comes back? You want to encourage them to be present, to think about um, going outside, smelling the air, looking at the pattern of the sky, looking at the leaves, to really recenter themselves and not let the worry take over. Meditation is a practice. It's something that will feel strange at first, but when you start to meditate and clear your mind, and sometimes people have a mantra like serene and strong, that can really help to lower the stress level. And then mindset is having hope, having faith that things can get better. Okay. All right. So how do we build connections? So it's really important because if young female breast cancer patients can feel very isolated, and it's really important to help connect them to support systems and groups that can really help them on their journey. So in Pennsylvania, we have Unite for Her, which is a organization that often provides like a welcome kit, a box that includes a cookbook for breast cancer patients. We have a Live Strong. Oh, I'm sorry. The Unite for Her also gives them vouchers to use for chair massage. I'm sorry, for massage therapy and chair yoga. And then we also have a Live Strong program that gives them a free membership to the YMCA and access to nutrition programs. And so that can be very helpful. And then Dr. Lucking, who presented in Module 1, started a local group here in Lancaster, Pennsylvania called Better Together that helps bring cancer patients together to do an activity, to learn about plant-based cooking, or sometimes wreath decorating. And that's a great way to bring patients together and share their journey. So overview, modifiable risks, lifestyle assessment, cardiovascular, metabolic, and psychosocial risks we're going to get to, risk factor management, and quality of life issues. So positive lifestyle changes, as we talked about, psychologically beneficial because it empowers them to take back control, because cancer, affects how you spend your time, how your body changes, things that you wouldn't have picked, and it can be very frustrating. And this, by showing them things they can work on to improve their quality of life and reduce their risk of cardiovascular risk and cancer risk, can really be very empowering and helpful. So the UCSF Health has breast cancer self-care and recovery lifestyle changes. So remember, lifestyle changes are not a written prescription that never changes. It's a dynamic process. I tell patients this should be the fun part of the journey. I'm going to work on trying things. Try a new recipe, try a new exercise, see what works, see what sticks. It's okay if some things are not a good fit, just try something else. First and biggest step is to care enough about yourself to care for you. This is self-care. So at this dynamic, busy time of life, it's really important to encourage them to self-care and make self-care a priority, and that it's not selfish. That if you are caring for yourself, you're better able to care for your child and your partner and your other family members. And so I really encourage them to weave self-care throughout their day, and especially before bedtime, to have a self-care routine to save that last few minutes of the day to do something that relaxes them before bedtime. So cardiovascular risks. So breast cancer and cardiovascular disease share many similar risk factors. So we know that they both share the pathway of inflammation. And we know that there are risk factors we can and cannot control. So age, if anyone out there knows how to control age, let me know. That obviously is not a risk factor we can modify, but we can control our weight, we can control our physical activity, and we can control our alcohol use. So in this slide, I like this slide because it shows in the middle the overlap. There are 5 out of 7 risk factors in this middle area that are modifiable. So that is diet, alcohol intake, obesity, being overweight, physical activity, and tobacco use. So these are the areas to really focus on with our patients and empower them to work on to make really big long-term, actually short-term and long-term effects on their life. So how do we calculate cardiovascular risk for this younger population? So historically, we had a prior risk calculator. Since I've been out of residency, it's been 20 years, we had a risk calculator for atherosclerotic cardiovascular disease, but it started at age 40. So it was kind of missing the earlier age population. So now we have the Prevent online risk calculator. It estimates a 10-year and 30-year risk for total cardiovascular disease, including atherosclerotic and heart failure. It is the first risk tool to combine cardiovascular, kidney, metabolic health measures. The equations are derived and validated with data from over 6.5 million US adults aged 30 to 79 years old without known cardiovascular disease. So this is so useful to guide primary prevention. It's focused treatment decisions to help us decide who should be on a statin, because statins often will save lives, because sometimes cardiovascular disease often will kill patients before cancer. So we need to be very mindful of the high cardiovascular disease risk in women and not overlook it, and use these risk calculators to identify who could benefit from a statin. Here is a link to the Prevent online risk calculator. That's from the American Heart Association. And I happen to sit on Wednesdays next to a cardio-oncologist, and he told me that coming soon is a chemoradiant calculator for cardiovascular events after breast cancer treatment. So this includes treatment-related risks. So people who get left breast radiation therapy are higher risk for atherosclerotic cardiovascular disease, and doxorubicin equivalent chemotherapy dosage. And also it includes a conventional cardiovascular risks, heart failure, hypertension, age, history of myocardial infarction or peripheral artery disease, obesity, renal failure, dyslipidemia, diabetes, and stroke or transient ischemic attack. So this is going to be great to have this risk calculator. All right. So in conclusion here, you remember this wonderful wheel that Dr. Lucking created. And it's as you know, it's a partnership between primary care and a collaboration with the specialists, oncologists, surgeons, radiation oncologists to provide the care and support to our patients. So now I want to talk about the evaluation and management of anxiety and depression. So remember, use screening tools and utilize your EMR, such as Epic. You can have screening tools like PHQ-9, GAD-4, to help automate screening for depression and anxiety. Reassure patients is super common on the cancer journey, and it can get better. So many patients come into me as the first thing they want to talk about is like, is this ever going to get better? And I reassure them, yes. I've seen many people, by working on these wellness pillars, and getting help from counselors. We have a wonderful counselor at our Cancer Institute who is very adept at dealing with these issues that come with young female breast cancer survivors, depression, anxiety, adjustment disorder, body image issues, boundary setting and self-care, and making that a priority. And the primary care doctors are best to assess for medication and long-term management of anxiety or depression events if they're needed. Cognitive dysfunction. So some of you probably heard the term for chemo brain, or brain fog. That term was created because a lot of times chemotherapy can cause cognitive dysfunction. It's important to reassure patients that it can get better. It's not permanent. Other causes can be endocrine therapy, radiation, and surgery. Take a good history of the cognitive problem and when it started. And there's not currently any good screening tools for it, but a lot of times patients will talk about it. Or I had a patient, it might manifest as they want to stop their estrogen inhibiting medicine. It's important to delve into that. Why? I encourage them not to stop it, talk to their oncologist about it, talk to you about it. I had a patient recently who came in on her first new patient visit with me saying she wanted to stop her tamoxifen. And on further discussion with the oncologist, we unearthed that she was being put up for a promotion with her job, and the cognitive function issues were making her not have the confidence to feel that she could do this, take on this promotion. So we referred her to occupational therapy, and speech therapists worked with her. And she was able to improve her cognitive function using the tools they taught her, and was able to get the promotion and not miss out on that opportunity. These are NCCN guidelines, survivorship care for cancer-related late to long-term effects, delves into more of these late effect symptoms. I wanted to encourage you, before I go on, review medication lists. I've seen that a lot of the specialists are not as comfortable with the medications that the patients come to them already on. So with these changes in weight, you might find that some of their medication dosage are not appropriate, or they might be on several medicines that can cause colitis. It might be causing diarrhea. And maybe the diarrhea, that side effect is not from their cancer bed. It might be from being on high dose of metformin, but they don't need that high dose of metformin anymore. Or they're on atorvastatin, which is the statin that's a higher incidence of colitis. So really, I want to empower you. We're best to review the medication list because we prescribe a lot of these medicines and we know their side effects and interactions. So brain health, 5 main contributors: being more active, staying stimulated, restful sleep, nourishing your body, and having a vibrant social life. So cancer-related fatigue, the definition is distressing and persistent. It's a subjective sense of physical, emotional, or cognitive tiredness or exhaustion. It's related to cancer treatment that is not proportional to recent activity, and it interferes with usual functioning. So fatigue, workup, and management. It's multifactorial. Explain the potential causes, cancer-related and not cancer-related, and look for other causes. Make sure they've had a recent thyroid-stimulating hormone, vitamin D and B12, fasting blood sugar, or an A1C if they have abnormal blood sugars. The weight changes, especially the weight gain, can definitely increase their risk for insulin resistance, prediabetes, and diabetes. And that can be very motivating to patients to work on the diet and exercise and weight loss to slow the progression towards diabetes. Look for sleep disturbances. Make sure, screen them for obstructive sleep apnea. I can't tell you how many patients I have done the stop bang screen for obstructive sleep apnea that's in EPIC and referred them for a sleep study. Of course, this is something you would do after treatment, not during treatment, because they have too much going on during cancer treatment. And then look for stress, depression, anxiety can also cause fatigue and sleep disturbances. Remember, the best treatment for fatigue is exercise, sleep. Naps are okay, but limit them to 30 minutes and earlier in the day. In summary, working together to meet the unique needs of young female breast cancer patients, survivorship elements, surveillance, wellness, and lifestyle, innovating and utilizing EMR to meet the needs of our patients, communication between primary care and oncology, and identifying which patients need more support. So that is the end of this talk. I want to thank you for this opportunity to share this information. I also want to thank my friend Sarah, who was very helpful while she was healing and on leave from work. She helped me create some of these PowerPoint slides and learn the tools on PowerPoint to create them. So thank you very much. I appreciate it.
Dr. Barbieri, thank you so much. That was a wonderful discussion. We do have a few minutes for questions. If you have any questions, please go ahead and pop them in that Q&A box. But in the meantime, I wanted to just sincerely thank Dr. Barbieri and Dr. Sivendran for sharing your expertise with us today. We are so grateful over here at FMEC for your time and your insights. This has been a wonderful presentation. I also wanted to thank our sponsors, the National Association of Chronic Disease Directors and the CDC, for their continued support here with this series. I encourage everyone to go to fmec.net and go over to the navigation section and click on projects to see all of FMEC's projects, but in particular, our breast cancer series now and some of our previous work as well. So I am not seeing any questions come in. I'm just seeing some thank yous coming in the chat for a wonderful presentation. So we are going to close it out today. And I look forward to seeing everybody at the next webinar. So thank you, everyone.
Thank you.